It's 13:45. A man's throat has been swollen for 3 days. Breathing is difficult. Swallowing is worse. The fever comes and goes, high enough to keep him awake at night, low enough that he can still walk. He does what any reasonable person in his position would do. He finds a physician. The physician is not hard to find. There is a small cluster of medical practitioners near Cheapside, recognizable by the signs outside their doors, a painted urine flask, the universal symbol of the profession. The physician invites him inside. The room is small, dim, lined with shelves holding ceramic jars and bundles of dried herbs. There is a wooden table, a stool, and a chart on the wall showing the zodiac overlaid on a human figure. He asks questions. When did the swelling start? Has there been blood? What has the patient eaten? He examines the throat. He nods. And then he reaches for a knife. Not cut the infection, not to drain the swelling, to cut the man's arm. Because in 1345, the cure for a swollen throat, the cure for almost everything, is blood. Specifically, removing it. The physician will open a vein, collect the blood in a brass bowl, and continue draining until the patient feels faint. This is not incompetence. This is not cruelty. This is the best medical care available in Western Europe. And every step of it is going to make the patient worse. To understand why, the starting point is not the knife. It's the theory. Everything a medieval physician did, every diagnosis, every treatment, every decision about when and how to intervene was governed by a single framework, the theory of the four humors. The theory came from the Greek physician Galen, who practiced in the 2nd century, and it had been the foundation of Western medicine for over 1,000 years by the time the man with the sore throat walked through that door. The theory was elegant. It was internally consistent. And it was completely wrong. Here is how it worked. The human body, according to Galen, contained 4 fundamental fluids: blood, phlegm, yellow bile, and black bile. Health was the balance of these 4 humors. Disease was their imbalance. Too much blood made you feverish and flushed. Too much phlegm made you sluggish and cold. Too much yellow bile caused anger and digestive problems. Too much black bile caused melancholy and lethargy. The physician's job was to identify which humor was in excess and restore balance by removing the excess fluid. A fever? Too much blood. Treatment? Drain blood. A cough? Too much phlegm. Treatment? Purge the system. Depression? Too much black bile. Treatment? Laxatives or vomiting agents, or both. The logic was perfect. The premise was wrong. And because the premise was wrong, the treatments were not just ineffective, they were actively harmful. The first step in any consultation was diagnosis. And diagnosis in 1345 did not work the way it works today. There was no stethoscope, no blood test, no thermometer. The 2 primary diagnostic tools were uroscopy and astrology. Uroscopy first. The physician would ask for a urine sample, collected in a clear glass flask and held up to the light. He would assess the color, the clarity, the sediment, and, yes, the smell and sometimes the taste. If you think that sounds absurd, consider that the physician had no other diagnostic tool. A 20-point color chart existed, ranging from clear white through shades of yellow, red, green, and black, each shade corresponding to a specific humoral imbalance. Pale urine indicated an excess of phlegm. Dark red urine indicated an excess of blood. Green urine, which did occasionally occur, usually due to infection, indicated an excess of bile. The system was remarkably detailed. It was also remarkably useless, because the underlying theory it was built on was wrong. But the physician did not know that. He had been trained for years, sometimes a decade in this system. Every teacher he had studied under used this system. Every text he had read confirmed this system. The color chart was not guesswork. It was the accumulated, organized, carefully transmitted wrong answer of an entire civilization. Then came astrology. The position of the stars and planets was not a supplement to medieval medicine. It was an integral part of it. The physician consulted an astrological chart before deciding when to perform a procedure. Each sign of the zodiac governed a specific part of the body. Aries ruled the head, Taurus the throat, Gemini the arms, and so on through all 12 signs. Bloodletting, the most common treatment, could not be performed when the moon was in the sign governing the affected body part. A sore throat under Taurus? Wait until the moon moves to another sign. The timing mattered because the physician genuinely believed that cosmic forces influenced the flow of humors through the body. This was not superstition in the way a modern person understands the word. It was integrated science, a system where astronomy, anatomy, and treatment were all part of one unified theory. The theory was wrong, but it was unified, and that unity gave it an authority that no single observation could challenge. Now, the treatment. Bloodletting. The physician selects a vein, typically in the arm, sometimes in the neck or behind the ear, depending on which humor is in excess and which part of the body is affected. He uses a phlegm, a small, sharp blade designed specifically for opening veins. The cut is quick. The blood flows into a brass or ceramic bowl. The physician monitors the quantity and the color. Dark blood is considered evidence of corrupt humors being expelled. You are drained until lightheadedness sets in, a sign to the physician that the excess has been removed and balance is being restored. In reality, the lightheadedness is the onset of hypovolemia, dangerously low blood volume. The body is not rebalancing. It is losing the very thing it needs to fight the infection that caused the swollen throat in the first place. A patient who walked in with a treatable infection walks out weaker, more vulnerable, and, if the bleeding was aggressive, in genuine medical danger. And the physician, watching the patient pale and weaken, sees exactly what his training told him to expect: the excess humor leaving the body. The treatment looks like it's working. It is the opposite of working. And there is nothing in the physician's framework that would allow him to see the difference. The physician's fee for this consultation was approximately 6 pence. A laborer in 1345 earned about 2 pence per day. 3 days' wages for a bloodletting session. And that was considered affordable. The expensive option was a full diagnostic workup: uroscopy, pulse examination, astrological consultation, and a prescribed course of treatment. That could run to 8 pence or more. The most expensive option, uroscopy, where the physician examined the urine by color, smell, and taste, cost 8 pence. 4 days of a laborer's income to have a man taste the patient's urine and announce that the stars were misaligned. For a family living on margins measured in pennies, the decision to visit a physician was not casual. It was an investment, a significant portion of the household's income, spent on the confident promise of a man in dark robes who examined the urine, consulted the stars, and opened a vein. And the patient paid, not because he was naive, because the alternative was no treatment at all. Or rather, the alternative was a different kind of treatment, cheaper, less prestigious, and sometimes more effective. though nobody knew that either. The hierarchy of medieval healers is worth understanding because it explains why the system persisted. At the top, the university-trained physician. There were fewer than 100 of them in all of England in the 1300s. They had studied for a decade, first the liberal arts, then medicine, at Oxford, Cambridge, or a continental university like Montpellier or Bologna. They read Galen in Latin. They could quote Hippocrates. They understood the humoral system with a depth and precision that most modern medical students would find impressive, if only the underlying science had been correct. These men did not touch patients with their hands if they could avoid it. Physical contact was the work of the surgeon. The physician diagnosed, prescribed, and supervised. He was, in the modern sense, a consultant. Below the physician, the barber-surgeon. Below the barber-surgeon, the apothecary, who mixed and sold the herbal preparations the physician prescribed. Below the apothecary, the local healer, usually a woman, often called a wise woman, who had no formal training but had accumulated knowledge of herbs, poultices, and remedies passed down through families and communities. And at the bottom, available to everyone and costing nothing, prayer, the parish priest, holy water, pilgrimage to a saint's shrine. For most people in 1300s England, peasants who could not afford sixpence, who lived miles from the nearest physician, the wise woman and the priest were the entire medical system. And here is the part that complicates the story in a way that nobody in the 1300s could see. The wise woman's remedies, the herbs, the poultices, the preparations based on centuries of trial and error, were often more effective than what the university physician offered. Not because the wise woman understood microbiology, she didn't, but because her remedies were empirical, based on what had been observed to work, rather than theoretical. Willow bark tea for fever actually reduced fever. A honey poultice on a wound actually prevented infection. If you could only choose one healer in 1300s England, the illiterate village woman with her herb garden was, on average, a better bet than the Latin-reading physician with his urine flask and his star charts. The physician's treatments were deduced from a theory. The wise woman's treatments were induced from experience. And experience, even without understanding, was closer to the truth. But bloodletting was only the beginning of the medieval pharmacy. The physician had a range of treatments, each more alarming than the last. Herbal remedies were the most common and the most varied. Some worked. Willow bark, containing the precursor to aspirin, was used for pain and fever and was genuinely effective. Poppy preparations provided real pain relief. Honey applied to wounds had genuine antimicrobial properties. These remedies survived because they produced observable results. They were the exceptions. The majority of herbal treatments were based on the doctrine of signatures, the belief that God had marked each plant with a visual sign indicating its medical purpose. Lungwort, with its spotted leaves that resembled diseased lung tissue, was prescribed for respiratory problems. Liverwort, shaped vaguely like a liver, was used for liver conditions. Walnuts, which look like small brains, were prescribed for headaches. The logic was theological, not empirical. And the results were exactly what you would expect from prescribing a plant based on what it looked like, rather than what it contained. Then there were the minerals. Mercury, quicksilver, was used internally and externally for a range of conditions. It was applied as an ointment for skin diseases. It was ingested as a purgative, the theory being that its remarkable density and fluidity would physically push corrupt humors out of the body. Mercury is, of course, toxic. Chronic mercury poisoning causes tremors, kidney damage, cognitive impairment, and death. The medieval physician had no concept of heavy metal toxicity. He saw a substance that produced dramatic physical effects, vomiting, salivation, sweating, and interpreted those effects as the body expelling diseased humors. The treatment was working. The patient was being poisoned. And the distinction between those two things was invisible within the framework of humoral medicine. Ground gemstones were another remedy: powdered pearl, crushed sapphire, gold dust, prescribed on the theory that precious substances would strengthen the body's vital forces. They did nothing. They cost a fortune. They were the luxury medicine of the medieval wealthy. And then there was the barber-surgeon. The barber-surgeon was not a physician. He had not attended university. He could not read Latin. What he could do was cut. The division of labor in medieval medicine was strict and, to the modern eye, bizarre. The university-trained physician diagnosed disease and prescribed treatment, but he did not touch the patient's body with a blade. That was beneath his station. Surgery, from pulling teeth to amputating limbs to draining abscesses, was the work of the barber-surgeon, who learned his trade through apprenticeship, not education. The barber pole, red and white stripes, originated as a symbol of this dual trade: blood and bandages. A barber-surgeon in 1300s London could shave your face, cut your hair, lance a boil, set a broken bone, and amputate a gangrenous leg, all from the same shop, with the same hands, and with the same set of instruments that were cleaned between uses by wiping them on a cloth. There was no anesthesia beyond alcohol, and, in some cases, a sponge soaked in opium and mandrake held under the patient's nose. There was no antiseptic. The concept of sterilization did not exist. Infection after surgery was so common that medieval surgical texts described the formation of pus as a positive sign. Laudable pus, they called it, indicating that the wound was healing. It was not healing. It was infected. And the distinction was, again, invisible. Trepanning, drilling or cutting a hole in the skull, deserves its own mention, because it is the procedure that most horrifies the modern imagination and most clearly illustrates the gap between medieval intention and medieval result. Trepanning was performed for severe headaches, seizures, skull fractures, and what the medieval physician called melancholy, conditions we might now classify as chronic migraines, epilepsy, traumatic brain injury, and depression. The theory, the evil humor or trapped spirit causing the condition, needed a physical exit from the body. The hole in the skull provided that exit. The procedure was performed by the barber-surgeon, using a trephine, a circular saw, or a sharp drill. Here is the remarkable thing. Some patients survived. Trepanned skulls found in medieval graves show evidence of bone regrowth around the hole, proof that the patient lived for months or years after procedure. This does not mean the treatment worked. It means the human body is more resilient than it has any right to be. The survival of some trepanning patients actually reinforced the physician's confidence in the procedure. Patients who survived, who felt relief, perhaps from reduced intracranial pressure in cases of genuine head injury, were evidence. Evidence that the theory was correct. Evidence that trapped humors had been released. Evidence that the hole in the skull had done its job. The fact that many other patients died from the procedure, or from the inevitable infection that followed, was attributed to the severity of their condition, not to the treatment itself. The system was unfalsifiable. It could not be wrong because every outcome confirmed it. And that is the deepest lesson of medieval medicine, the one that sits underneath all the bloodletting and the mercury and the holes in the skull. The system was not random. It was not chaotic. It was rigorously organized, carefully taught, internally consistent, and supported by centuries of accumulated authority. It had textbooks, universities, licensing procedures, professional hierarchies, and diagnostic protocols. It had everything a medical system needs, except the one thing that would have made it work: a correct understanding of what causes disease. Galen's humoral theory was wrong. It was wrong in the 2nd century when he wrote it. It was wrong in the 1300s when the man with the sore throat walked into that physician's office. And it would remain wrong for another 300 years until the development of germ theory in the 19th century finally replaced it. For 1,500 years, the most brilliant medical minds in Western civilization diagnosed disease according to a system that had no connection to the actual mechanisms of illness. And they could not have known. The tools to see bacteria did not exist. The concept of microbiology did not exist. The intellectual framework to even ask the right questions did not exist. They were working, brilliantly, diligently, with genuine compassion in many cases, inside a system that was built on a foundation that was not there. Nobody told them, and they had no way of knowing. The Black Death tested this system to destruction, and it held. That is perhaps the most remarkable and the most disturbing part. When plague arrived in England in 1348, the medical establishment responded exactly as its training dictated. The University of Paris issued an official report attributing the epidemic to a conjunction of Jupiter, Saturn, and Mars that had corrupted the atmosphere. Physicians recommended carrying posies of flowers to purify the air around the face. They advised against bathing. Open pores admitted the miasma. They bled patients who were already weakened by fever. They prescribed mercury compounds and theriac, a complex mixture of dozens of ingredients, including opium, that was considered a universal antidote. None of it worked. The plague killed a third to half of Europe's population, regardless. And afterward, after the most devastating medical failure in the history of civilization, the humoral system was not questioned. Not once. The physicians who survived the plague concluded that the disease had been too powerful for human medicine to counter, not that the medicine itself was wrong. The framework absorbed the failure and continued. That is the power of a system that cannot be falsified. When the treatment works, the theory is confirmed. When the treatment fails, the disease was too severe. The theory survives either way. And it did survive. For 3 more centuries. Here's what that means if you think about it honestly. These were not stupid people applying a stupid system. These were intelligent, educated, dedicated people applying a sophisticated system that happened to be built on an incorrect premise. The physician who bled the man with the sore throat had studied for a decade. He could diagnose conditions with remarkable precision within the framework. He could predict the course of an illness within the framework. He genuinely wanted his patient to recover. He believed, with the certainty of 1,000 years of accumulated tradition, that what he was doing would help. And he was wrong. Not because of a personal failure. Because the civilization he lived in had not yet developed the tools to see what was actually happening inside the human body. That gap between the best available knowledge and the actual truth is not unique to medieval medicine. It is a feature of every era, including this one. The man with the swollen throat paid his 6 pence. He was bled. He was given an herbal preparation, perhaps sage and honey, which might have actually helped, or perhaps a mercury compound, which would not. He was advised to avoid bathing. Open pores admitted corrupt air. He was told to return in 3 days if the condition persisted. In 3 days, weakened by blood loss and whatever the herbal preparation had done, his condition had worsened. The physician noted this, consulted the stars, and bled him again. The infection, a bacterial infection that a modern course of antibiotics would have cleared in a week, continued to spread. There is no record of what happened to this particular patient, because there was no particular patient. He is a composite, drawn from the medical texts, the case records, and the cemetery evidence of 1300s England. But the pattern is real. The pattern repeated thousands of times, across centuries, in every city and village in Europe. A treatable condition, a confident physician, a treatment that made it worse, and a patient who trusted the system because the system was all there was. If you had been that patient, and statistically anyone living in 1300s England would have been at some point, the experience would have been indistinguishable from competent care. The physician's room looked professional. His instruments were clean by the standards of the era. His confidence was total. His bedside manner, by surviving accounts, was often genuinely kind. He explained the diagnosis in terms that made sense. The humor is in excess. The balance must be restored. The stars indicate that today is favorable for the procedure. He did not rush. He did not dismiss. He listened, examined, diagnosed, and treated, exactly as he had been trained to do. And every step moved the patient further from recovery. That is not a horror story. That is something quieter and more unsettling. That is a story about the limits of knowledge, and about what happens when an entire civilization does its honest best, and its honest best is not enough. The doctor couldn't help, but at least he tried. At least he had training, a theory, a framework, and what he believed was compassion. Next time, a place where nobody tried at all. Medieval prison did not have a sentence. It did not have a release date. It did not have a bed or food provided by the state, or any mechanism to determine when or whether the person inside would ever come out. It barely had a floor, and the people held there had often not been convicted of anything. That's next.